In today's video, we are going to be talking about anxiety disorders. This is brought to you by Dirty Medicine. Before I get into today's video, if you like what I'm doing on this channel, you want to give back, you want to support Dirty Medicine and my quest to provide free medical education, please consider clicking the join button. You can find that join button on my channel homepage on the bottom of every video, and also as a link as the first link in the description of any video. When you click join, you'll become a Dirty Medicine member, and in exchange for providing secure monthly financial support to my channel in the form of $4.99 a month, you'll get some cool perks. One, you'll get the Dirty Medicine logo after your name, so whenever you post publicly on my channel, everybody will know that you're a Dirty Medicine member. Two, you'll get access to the locked section of my channel, which is under the community tab. Right now, I'm polling members, asking them what topic they'd like the next video to be, but in the future, they might get access to exclusive content. Now let's get into today's video. We are talking about anxiety disorders, which means that we're going to be talking about everything that you see on this slide. Generalized anxiety disorder, adjustment disorder, panic disorder, specific phobia, agoraphobia, social anxiety disorder, post-traumatic stress disorder, and obsessive compulsive disorder. Now, these are all a lot of different psychiatric disorders, but they all are considered anxiety disorders. So let's go through them one at a time. As we go, I'll point out what's very important for you to know, and where relevant, I'll give you a really cool mnemonic to memorize something that you need to know for USMLE or COMLEX. So let's get started with generalized anxiety disorder. Now, as many of you know, if you've been studying the psychiatry section of your textbooks, you know that the timeline is very, very high yield. So in generalized anxiety disorder, the timeline is 6 or more months. The symptoms include excessive worry, irritability, fatigue, tension, decreased concentration, and restlessness. So you think about your anxious friend who constantly is worrying excessively about doing poorly in school. Chances are they have a lot of these symptoms. Now, of note, these symptoms are not associated with a specific person or an event. And this is important. This is actually very high yield because in generalized anxiety disorder, the person is not worried about a specific thing. The worrying is just generalized. As the disease or the disorder implies, it is generalized. So it's not specific worry about a specific thing. And therefore, in a question stem on USMLE or COMLEX, if they give you somebody with symptoms of anxiety, but those symptoms are all specific to one singular event, chances are it's not generalized anxiety disorder. The treatment for generalized anxiety disorder is SSRIs, SNRIs, and CBT, which stands for cognitive behavioral therapy. So you might see that written out on an exam as an answer choice as psychotherapy, or the test writer could be much more specific and write cognitive behavior therapy. Both of those terms are used interchangeably. It would be akin to writing antidepressants or SSRIs. So you're just getting a little bit more specific when you write CBT. Now, something that gives medical students a really tough time is comparing and contrasting generalized anxiety disorder with adjustment disorder. And people don't quite understand what adjustment disorder is, so I want to simplify this and make it stupid and simple. So adjustment disorder, how does it work? Well, there's some triggering event. So some event happens which causes mood symptoms. And now the question for deciding whether or not this is adjustment disorder is asking yourself, assuming that you're the physician, how long have these mood symptoms been going on since the triggering event? And the answer to that question really guides you clinically, because if the event and the subsequent mood symptoms have only lasted up to 6 months, meaning basically up to the last day in the 5th month, that's adjustment disorder. But as soon as those symptoms go beyond the 6-month mark, so now you're at 6.0 months or greater, if they're still having those mood symptoms in response to the triggering event, that's generalized anxiety disorder. So it's extremely high yield for USMLE and COMLEX to understand that some event happens, it causes mood symptoms, and when I write mood symptoms, I'm referring to either anxiety symptoms or depression symptoms, and then those symptoms will last either up to 6 months, and therefore it's adjustment disorder, or 6.0 months and beyond, and therefore it automatically converts to generalized anxiety disorder. So you need to understand that 6-month timeline. If the symptoms are still going on, then what was previously called adjustment disorder is now converted to generalized anxiety disorder. So let's go through this with a stupid example. Let's say that a man gets a divorce. As a result of his divorce, he has constant worrying. He's very irritable. He's just not pleasant to be around. Now the question is, how long do those symptoms go on for? And let's assume in this example that he has gotten that divorce 3 months ago, and therefore these symptoms have only been going on for 3 months. Therefore, we would kind of go to the left side of this flow diagram, and therefore we would diagnose him with adjustment disorder. We would not call this generalized anxiety disorder because these symptoms have not been going on for at least 6 months. So very, very high yield, know the timeline, and although generalized anxiety disorder technically is not symptoms to a specific event, if it's an adjustment disorder, it can be converted into the generalized anxiety disorder, assuming that those symptoms go on for more than 6 months, even though those symptoms are related or follow a specific triggering event. So high yield summary, here we go. Generalized anxiety disorder, red on the left, and adjustment disorder will be blue on the right side of this slide. The timelines, GAD 6+ months, adjustment 0 to 5 months. GAD, no specific event. Adjustment disorder follows a specific event. Generalized anxiety disorder, you treat with SSRIs and CBT. Adjustment disorder, you treat with CBT and SSRIs. And I switched the order there because technically you don't really need to treat adjustment disorder. But if there is going to be pharmacotherapy, then it will be SSRIs or SNRIs. But typically you want to start with psychotherapy, which is why I put CBT first. Now, how do you remember this, right? You're struggling to fit all of this information into the very precious amount of brain space you have left. You're feeling exhausted. You're thinking to yourself, Dirty, I want to be a vascular surgeon. Why the hell do I care about psychiatry? Well, let's give you a mnemonic then. So adjustment disorder is adjust 0 to 5 months. All right. Adjustment disorder is adjust 0 to 5 months. So this will help you remember that the adjustment disorder only lasts up to 5 months. And if it goes 6 or more, you convert it to GAD. All right, done. We've knocked off the first 2 anxiety disorders. You're well on your way to being the next Freud. Now let's talk about panic disorder. Panic disorder has a timeline of 1 or more months, and the symptoms are pretty obvious. It's your friend who has panic attacks. What's a panic attack? Well, with the panic attacks, you're going to get things like palpitations, shortness of breath, hyperventilation, a feeling or sense of impending doom or death. For whatever reason, that's the biggest buzzword that shows up on USMLE and COMLEX. Impending doom, impending death. These patients just feel like they're going to die because they can't catch their breath, their heart is racing, they start to sweat, they're uncomfortable. And, if you've ever seen someone have a panic attack, this is truly, truly a scary thing to watch. Tachycardia. So all of these symptoms, these are what the layperson refers to as a panic attack. Now, what makes it panic disorder is that the patient has either fear, worry, or in some way changes their behavior, and that's all related to the fear of having another attack. So it's interesting because it's not necessarily the panic attack itself that is the debilitating part of this disorder. I mean, certainly, don't get me wrong, a panic attack sucks, and if you've ever seen someone have one, it looks awful. But what makes this panic disorder is that the patient is fearful of having another panic attack, usually in a public situation, worries constantly about having that next panic attack, or in some way modifies or changes their behavior to accommodate this idea of what if I have another panic attack. So, for example, patients might not want to take public transportation because they don't want to have a panic attack on the bus or on the train, and that's panic disorder. Now, as far as treatment goes, there's 2 options here. One is maintenance treatment, right? This is like the long-term treatment. This is what you would put the patient on to hope that you would be curing or treating the panic disorder, and that would be either SSRIs or SNRIs plus therapy. But there's also abortive treatment. So if someone is past the point of being able to stop the panic attack and now they're having their full-blown panic attack, you want to abort that panic attack with a benzo. Okay, and you see the picture here of Tony Soprano, who suffered from panic attacks. All right, we've talked about panic disorder. Now let's talk about some phobias. So we'll start with specific phobia. The timeline for specific phobia is 6 or more months, and the symptoms are an intense fear of a specific object, okay? So these are your things like people that are scared of spiders, people that are scared of blood, people that are scared of heights. These are specific phobias. The phobia is specific to one specific object or thing. Now, these are almost always ego dystonic, which means the person is aware of this and the person doesn't like this. So ego dystonic means the person dislikes the problem or the mental illness that they have. The treatment for specific phobia is systematic desensitization, which is a fancy way of saying that we're going to expose you to the phobia, and over time we're going to give you more and more and more exposure until you're comfortable with it. So this is the way that if someone has a fear of clowns, first you show them a clown glove, and then you show them clown pants, and then you make them squeeze a clown nose, and then you expose them to a clown, and then you put them in a movie theater full of clowns, right? That's systematic desensitization. That's the treatment for specific phobia. That's a form of therapy, so you could see the answer written on USMLE or COMLEX as psychotherapy, but it's a very niche type of therapy, and that's known as systematic desensitization, so definitely know that. Now, related to specific phobia is agoraphobia. And if you were a kid and watched Hey Arnold, this is Stoop Kid. So Stoop Kid's afraid to leave his stoop. Agoraphobia is the irrational fear of either public spaces or crowds, closed spaces, public trans, or standing in lines in general. So agoraphobia is just people are scared to go out in public. And because of this, the way that agoraphobia is depicted in movies and TV shows is people that are scared to leave their home, because as it gets more severe, people are so worried about all of these things that not only do they want to stay home and never leave their home, but it becomes a panic disorder because they start to have panic attacks when they think about what it might be like to go out in public, to ride the bus, to stand in line at an amusement park. So agoraphobia for USMLE or COMLEX, you should know, is incredibly comorbid with panic disorder. Now, there are a lot of phobias, and you've probably heard just throughout your life, blank phobia, blankophobia, and those words are hard to keep straight. So for your purposes, for USMLE and COMLEX, the way to remember what agoraphobia means is I don't want to go anywhere. Ago should remind you of agoraphobia, and I don't want to go anywhere. I don't want to go anywhere will remind you that those with agoraphobia typically just want to stay home all day because they fear public spaces. So that's agoraphobia. The last related disorder in this category is social anxiety disorder. Now, this used to be called social phobia, but this is a specific fear of embarrassment in social situations. And if you watched the movie Elf, the character that was played by Zooey Deschanel, she had a fear of singing in public spaces. So there's that one scene where she's singing the Christmas Carol in the shower, and she tells Will Ferrell's character, the elf, that she doesn't like to sing in public. And then lo and behold, she overcomes this social anxiety disorder at the end of the movie where she sings the Christmas Carol, bringing Christmas cheer and launching Santa's sleigh back into the air. So this is social anxiety disorder. It's the specific fear of embarrassment in social situations. The treatment here is pretty interesting. Maintenance treatment is SSRIs and therapy, specifically cognitive behavior therapy. But for the performance subtype, and what I mean by performance is people that don't like things like public speaking or giving a presentation, you actually can treat with beta blockers and just reduce their sympathetic drive to get them more comfortable. And again, just like panic disorder, abortive treatment would be with benzos. So that's social anxiety disorder. If we take a look back at our progress thus far in this video, you guys are killing it. You're well on your way to being psychiatrists. Some of you may have already gone on Amazon and ordered some sick sweater vests because that's what psychiatrists wear, apparently. Next disease, post-traumatic stress disorder. So post-traumatic stress disorder seems a little complex to a lot of medical students. Like, people understand the core symptoms of it, but putting them together and really thinking about this and conceptualizing this seems to be difficult based on the emails that I've gotten. So let's simplify this one and just keep it stupid and keep it simple. So what happens in PTSD, post-traumatic stress disorder? Well, there's some potential life threat, which leads to trauma symptoms. And when you hear psychiatrists refer to trauma symptoms, they're talking about things like hyperarousal. So, the person is constantly in a heightened sympathetic state, or you tap them on the shoulder from behind and they turn around ready to fight because they're scared that something was going to happen to them. You also get avoidance symptoms. So not only are the patients hyper aware of everything that's going on, but they're going to take actions to actively avoid whatever the potential life threat was that gave them post-traumatic stress disorder. They also have the intrusive symptoms. So intrusive symptoms are the nightmares and the flashbacks surrounding the trauma or the details or events surrounding the trauma. So the classic example is a war veteran who had another soldier that he or she was close with die in combat. And therefore, when PTSD sets in, the war veteran is having nightmares about fighting or serving with their lost friend, and flashbacks about the actual death of their friend. So those are the intrusive symptoms. And then lastly, you get a cognitive change, and that can look a lot like major depressive disorder or generalized anxiety disorder because cognition and mood changes. So some potential life threat occurs, trauma symptoms eventually set in, and now the question, like everything in psychiatry, is how long do the symptoms last for? And the answer to that question will determine our diagnosis. So if the trauma symptoms that you see on this slide last less than 1 month, so not up to 1.0 months, but let's say 1 week or 2 weeks or 3 weeks, we call that acute stress disorder. But if the symptoms last for 1.0 or more months, then we indeed have post-traumatic stress disorder. So the timeline is very important. This is kind of like brief psychotic disorder versus schizophreniform, where you've got up to 1 month and then 1+ months. But for PTSD, it's less than 1 acute stress, 1 or more post-traumatic stress. All right. Now, the treatment here, regardless of if we're talking about acute stress disorder or post-traumatic stress disorder, is going to be SSRIs plus therapy. And then you can actually do symptomatic treatment for nightmares specifically. If the core component or the core symptom are nightmares, you treat that with prazosin. Okay, so that's post-traumatic stress disorder. Let's wrap up our discussion of anxiety disorders by talking about obsessive compulsive disorder, better known as OCD. So OCD, let's talk about the concept of OCD. So the patient gets these intrusive ideas. These are referred to as obsessions. And those intrusive ideas lead to distress. So the person has these ideas racing through their brain. They can't stop obsessing over these obsessions, and therefore they have distress. And the only way to get rid of that distress is to engage in repetitive rituals. So the person has obsessions. The obsessions might be partially relieved by the acting out of compulsions. And these obsessions leading to compulsions is why this disorder is termed obsessive compulsive disorder. Let's do a quick example to make sure that everybody is on the same page. So a patient might have an obsession that they left the front door to their house unlocked. So they're constantly worrying, did I leave the door unlocked? Oh my God, did I leave the door unlocked? What if the door's unlocked? So that obsession is running through their brain nonstop. And they might be upstairs laying in bed trying to Netflix and chill, but they can only think about, what if that front door is unlocked? Someone could break in and murder me. That obsession is running through their head. And because of that, they experience subjective distress. So they are anxious, worried. It's nonstop. And as a result of this obsession, the only way to relieve that distress, and it will be only partial relief, is to go back and check if the front door is locked. So the compulsion component here is going to the front door and seeing that it's locked, putting their hands on the lock, turning the lock whichever way locks the door, even though it's already locked. And they do that over and over and over again. So you've got the obsession. The obsession is the thought that can't get out of their head. It causes distress. The distress is partially relieved by the compulsion. But since it's only partially relieved by the compulsion, the patient goes back and keeps doing the compulsion because they never get the full relief. Because even though the door is locked, the obsession is that it's not locked. And the compulsion checks the obsession and checks if the door is locked. And that cycle just continues over and over again. Let's do one more example. This is another one that you might see on USMLE or COMLEX. The person thinks that their hand is somehow contaminated with germs. So they have this obsession running through their head over and over and over again. My hand is dirty. My hand is dirty. Ugh, what if I have a disease on my hands? And that causes them distress. And the only way to partially relieve that distress is to wash their hands over and over and over again. These people literally might wash their hands up to 30 times. The skin is going to be raw and red and just sloughing off their hand like a positive Nikolsky almost, because they're washing it so much and irritating their skin. So you've got the obsession or the thought ruminating, causing distress, leading them to engage in the compulsive behavior. Okay, so this is the overall concept of OCD. Obsession leads to distress. Distress is partially relieved by compulsions. Obsession comes back, and the cycle continues. Now, what's really, really high yield for USMLE and COMLEX is to know the difference between OCD, obsessive compulsive disorder, and OCPD, which is obsessive compulsive personality disorder. Right? So OCD is a disorder. OCPD is a personality disorder. And we don't really need to get into the nuances of this, but the big takeaway for you, because it's incredibly high yield, is that OCD is ego dystonic, OCPD is ego syntonic. Now remember from earlier, I told you that ego dystonic means the person is aware of it and struggles with it and doesn't like it. So OCD, patients with OCD really struggle. They hate their OCD, generally speaking. OCPD, because it's a personality disorder, the person's largely unaware. Because remember that personality disorders are pervasive traits. They're inherent to a person's being or personality. So the PD, the personality disorder, is ego syntonic, meaning the person is not really aware of it and doesn't necessarily mind the traits. Now, how do you remember the difference in this terminology? Well, if it's ego dystonic, the person dislikes it. And they dislike it because they're aware of it. It causes them to struggle in life. So dystonic means they dislike it, they're aware of it, they struggle with it. Syntonic, the person is unaware of it, doesn't necessarily mind it. So that's it. We did it. We went through all of the anxiety disorders. You guys are now ready to be psychiatrists. Everybody go on Amazon, order those sweater vests, get the comfy chair, and get ready to dominate USMLE or COMLEX.